Good afternoon, everyone. Thank you for tuning in today. And in this segment of the show, we will be looking at the biomechanical interventions that are used when treating a person with Duchenne's muscular dystrophy. The biggest intervention that a child with DMD will receive is physical therapy. From the time that they are diagnosed on, they will constantly need to get treatments and adapt their treatments as their disease progresses. There are three main stages that they will go through, and in each stage, the physical therapist will approach their treatment differently. In the first stage, the early stage, it goes from diagnosis to about age 7. The main goal in this stage is to keep the child up and moving and independent. At this point in the diagnosis, they still have good movement and flexibility about all their joints, and this allows for them to participate in active exercise. The tricky thing with active exercise is that the repetitive loading of this can cause unneeded stress on the muscles and actually damage them. So instead of doing active exercise, you can do swimming. This is one of the first things recommended by physical therapists because it allows for greater range of movement of their muscles without the stress that at running or something like that could put on the muscles. Another important part of the therapy at this point is stretching. While in this stage you will only start doing it to get the child into the daily routine of doing it because it is not as important. So the areas that you focus on at this stage are going to be the ankle, calf, and hamstrings. So for a calf and ankle stretch, you will grab right here at the base of the ankle, hold the thigh down, and push up on the foot, and you will hold that for 60 seconds. You do these kinds of stretches in the first stage because your ankle and calves are usually the first thing to stiffen up. The last thing in the early stage is the introduction of the use of orthosis. For this stage, you'll use an ankle-foot orthosis that keeps the ankle in a fixed position so that there's not twisting or bad movement during sleep, and you will only use these at night. The next stage is the middle transitional stage, which will usually last from age 7 into their early teens. The exercise protocol for this stage is pretty much the same as that of the early stage, except that you will have to do some slight adjustments based on the strength that the child now has. For stretching in this stage, you will continue to do your knee, ankle, and hip. You will continue to do knee, ankle, and hamstring stretches, but you will introduce hip flexor stretches because at this time the hip flexors start to weaken, and stretching will help prevent the development of contractures. So for a hip stretch, it's best to have them lay on their stomach or on a wedge, and what you will do is pull their leg up, press down at the top of their butt, and pull up and in, and you will also hold this one for 60 seconds. In this stage, you also will use orthosis, but for this one, you will be using a knee, ankle, foot orthosis, which can actually help with walking, but not all physical therapists decide to use this. If they don't use this, then you can use standing frames to help get stretching and balance stability that you need. The last stage is the adult stage, which goes from the late teens on. At this point, children have become non-ambulatory, which makes things more difficult. Due to the fact that they have limited movement, active exercise is very difficult, so by putting them in the pool, you allow them to get a little bit of freedom out of their chair because they're usually confined to their chair most of the time. This limited range of movement greatly increases the chances of the child developing contractures as well as scoliosis. At this point, once you have been confined to your chair permanently, there's a 90% chance that you will develop scoliosis within 2 years of being confined to the chair. It is important for you to continually monitor your child's posture. That way you can catch it early on because that is key for doing surgery. At this point in the disease, sometimes your therapist will recommend doing stretches of your upper extremities so that you can stretch out the arms, shoulders, elbows, and hands because those can become stiff with the constant use of being in a wheelchair. So aside from physical therapy, there are a few other things that can be used to help with DMD, such as splints, standing frames, and surgeries. So the first splint that is used is the ankle-foot orthosis. This splint is used almost exclusively at night while the child is sleeping to keep the foot in a desired position so they don't get tangled up and stretched the wrong way during sleep. The use of these starts when dorsiflexion has been lost in the foot, and it is important that they're not used during the day while the child is still able to walk because they can then impede on the ability of them to do so. When the foot is in the brace, it is in a fixed position that keeps the ankle from being out of its abnormal position that would lead to the development of a contracture. The fixed position slows the loss of plantar flexor muscle length, which is very important in order to keep them walking. If the AFOs are worn during the day, it can actually increase the external flexion movement at the knee, external flexion moment at the knee, which can weaken the quads and cause them to have a shorter ambulation period. Another splint is the knee ankle foot orthosis. This splint is introduced when walking has started to become more difficult. While these splints won't help them to be completely independent when they walk, they can help them to be up and walking longer. Having the ability to walk longer can delay the development of contractures and make it less likely that they will need a spinal surgery later on. The splint works because it applies force around the joint in order to stabilize the knee. With the joint stabilized, they are able to control their movements better. These braces also help to improve their balance, which can be a preventative factor in developing contractures. When a child has to put his joint into a weird position in order to compensate for balance, it can cause a contracture because the muscles around that joint start to shrink and harden. Standing frames are another device that is used in the later stages of DMD. It is best to use them a few hours each day. They will help to lessen the formation of contractures, especially since at this stage the child is confined to their wheelchair most of the day. The standing frame can also help to improve the bone mineral density because it is putting more of a load onto the bone than the bone is used to at this point in time. They are also helpful in delaying the development of scoliosis because you are getting the child up and moving and getting them out of their normal fixed position. They also allow for stretching of the ankles, knees, and hips all at the same time. The last intervention is surgery. In the last stage of DMD, because the child is confined to their chair, it will often cause them to develop scoliosis. This develops quicker once they have been confined to their chair because their muscles start weakening faster, thus leading to the curve in their spine developing. The way that this is fixed is that they will surgically go in and place a rod to stabilize the spine. This rod allows the child to have better balance and posture in the chair, which can lead to a reduction in back pain and cause them to have better breathing. The tricky thing with this surgery is that oftentimes surgeons are hesitant to do it based on the cardiovascular and the respiratory systems of the child, which is why, as I mentioned earlier, detection is key, because if surgery is not an option, then you will have to use braces to help stabilize the spine, which are not a permanent fix and only work for so long. So that's all for this segment. Thank you for tuning in.